You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 313 of the podcast. And in this one, I got on Dr. David Burns. I wanted to get David on the show for a while, so it's good to finally get him on. David is a psychiatrist and is currently Adjunct Clinical Professor Emeritus of Psychiatry and Behavioral Sciences at the Stanford University School of Medicine. He's also author of the best-selling book Feeling Good, as well as many other books, including the more recent book Feeling Great. David has also developed the therapy TEAM-CBT. In this, we discuss his own therapy journey, so how he became to do the work that he does. We talk about his own challenges with anxiety. He tells plenty of stories to illustrate this, as well as we discuss motivation for doing exposure and response prevention therapy. He gives client case examples to illustrate this. We discuss the hidden emotion model and much more. So I really enjoyed this conversation with David. So David does have some unique perspectives and different ways of looking at things. Some of this may not resonate with you and some of it may. So just pick what works for you, and if it doesn't, that's okay too. But I wanted to share some different perspectives as part of the growth of the podcast. And the other thing, more of a pre-warning, he does use the word cure. That's his choice. So I just wanted to give you a heads up, because I know when that word's come up on the show before, it has triggered some of you. So just to give you a pre-warning on that, but he's perfectly in his right to use it. That's how he sees things. And obviously I didn't ask him to define what he means by the word cure, because everyone has their own definition. But yeah, well, like I said, really enjoyed this. It's a different view and different perspective to things that have been covered before, so I hope you enjoy it. And thanks as always to NoCD for supporting the work that I do. NoCD offers affordable, effective, convenient therapy available in the US and outside the US. If you wanted to find out more about their therapy services and whether they take your insurance currently, head over to go.treatmyocd.com/COCD stories, or the link will be in the episode description. So thank you to you guys for listening. I deeply appreciate it. And thank you to David for his time. Without further ado, here he is. Welcome to the show, David.
Oh, thank you, Stuart. I'm totally thrilled to be on your show today. It's an honor, and I'm really psyched.
Yeah, it's an honor to have you here. So first question for me then is, whenever I get a clinician on or a therapist, I always like to know what got them into being that.
Yeah, well, when I went to college, I was a philosophy major. I thought it'd be great to major in physics, and I actually took a couple physics classes, but realized the physics students were so much smarter. I had no chance of survival. So I majored in philosophy, which I loved, and was going to go into graduate school in philosophy. But my senior year, we had to do our dissertation on something, or our honors thesis or some such thing. And one of my roommates, who did go into physics, and he's now a world prominent physicist, Phil Allen, says, "Why don't you do your honors thesis on this guy Wittgenstein?" And I said, "Well, I've never heard of who's Wittgenstein." And he said, "Well, here's this guy that the rumor is he solved all the problems of philosophy, but only 7 people in the world can understand what he was trying to say. And so if you can, read his book, Philosophical Investigations, and understand it, they won't be able to challenge you when you have to defend your honors thesis, because it's a certainty that none of the faculty are among those 7 people in the world who can understand it." So I started reading this book, and I couldn't figure out what the hell he was talking about. It was like, think about a bricklayer. Well, let's say a stonemason. He's building a wall, and he has an apprentice. So every now and then he shouts "stone," and then the apprentice hands him the stone, and he puts it in the proper place in the wall he's building. He says, and that's really about all that's going on there. Now can you understand why Aristotle was so in the wrong, where he went wrong? And I would think, no, I don't know what you're talking about. and then he had all these numbered paragraphs kind of thing. And then he'd say, now think about a piece of string. And it's all these threads kind of woven together. And there's no one thread that goes from one end to the other. And he says, that's just like the word game. There's no essential meaning of the word game. Like, you can say, oh, a game has to have competition, but there's games with no competition. You say it has to have two teams, but there's like solitaire where there's only one person. He says there's no essence to it, just used a sound that we use in a lot of ways. He says, now can you let go of the free will problem? And I would think, no, I don't know what the hell you're talking about. And I kept trying to figure this out. And spring, it suddenly dawned on me. I was walking across the campus of Amherst College, where I was a student, and it suddenly dawned on me what he was trying to say. And I saw the solution to all the problems of philosophy that had vexed me. And I went to my supervisor and said, I don't need to go on anymore in philosophy. I think I'll do psychology instead for graduate school. That's something practical to help people. And he said, oh, no, you have to go to medical school. That's much better. You'll be a psychiatrist. And I said, well, what's the difference between a psychiatrist and a psychologist? He says, well, a psychiatrist can prescribe drugs. And I said, but I couldn't go to medical school because I'm not pre-medical. I haven't even had a biology class. He says, oh, don't worry about that. He says, you can talk your way into anything. So I got admitted to Stanford Medical School, and boy, that was a huge mistake. I think I was the worst student they ever had. All I wanted to do was to learn how to do therapy, psychotherapy. And I dropped out of school for a year twice, thinking, I'm not a doctor. I don't want to be a doctor. But I finally finished medical school, did my internship and residency, and then I got really excited about psychotherapy. At first, I did research on drugs, and then I realized our research showed even in the 1970s that this chemical imbalance theory of depression was fraud. It was not valid, and I had a grant to stay at the university on the tenure track doing research on this chemical imbalance theory. I had a wonderful career. I was winning awards for my research on brain chemistry. But I thought, I don't want to do this. This really sucks. I don't want to spend my life on this theory that will never help anyone. It'll never pan out. Then I heard about this cognitive therapy that Beck had created at Penn. He was at the same university I was at. And the department chairman says, well, your drugs aren't working. The therapy you've learned to do as a resident isn't working. Why don't you check out this new thing? And I said, it sounds stupid. Beck says that negative thoughts cause depression. You can train people to change the way they think, and then they'll change the way they feel. I said, that couldn't possibly be true. My patients are severe. They're suicidal. And then the department chairman says, well, why don't you do it as part of your research work? You could just go to a seminar and try it out on a few of your patients and prove to yourself that it wouldn't work. And I said, hey, that's a good idea. So I went and I started to try these techniques on my worst patients, like people who just referred from the intensive care unit for an almost successful suicide attempt, and patients that I hadn't been able to make a dent in with the stuff I was trained to do, which was most of my patients. And all of a sudden they started recovering. I could not believe it. It was so amazing to me. That's why I wrote my first book, Feeling Good, just so people would know here's this new alternative to taking all these medications and years of talk therapy. And I just decided to leave academics. I sent my grant money back to the federal government, and I just said, I don't want to, this is going to be a waste of time to do this kind of research. And I want to develop this new cognitive therapy. So that was the history of it. And I left the university, and they put such pressure on me. They said, you're burning bridges. You've got a fantastic career. You're already lecturing all around the world. You're just a young man. And they said, once you leave, there's no going back. You'll never do research again. And nothing could have been further from the truth. And it was the day I left, and opened my private practice. I said, I'll stay on the faculty as a volunteer. You won't have to pay me. And I'll do some teaching in exchange for that. But that was probably the happiest day of my life. And then I helped to develop cognitive therapy. I wrote my book, Feeling Good. It started slow. It's eventually sold over 5 million copies. And cognitive therapy has swept the world. But once I got into practice, I began to say, hey, this is great, but it doesn't help everybody. Why not? What's the missing ingredient? And then I found a lot of ways to improve it, and it morphed into this new approach that's even more powerful, substantially more powerful than the original cognitive therapy. So there's my history in a nutshell. And to tell you the truth, before I went back and did my internship, my wife and I were homeless. I had just dropped out. We were living down in Monterey, California, sleeping on people's floors at night. We had a baby coming. We didn't have any money. And I tried to counsel people for free. That's all I ever wanted to do. So I'd counsel people on the beach, or I'd go to a coffee house and sit down with someone. And if they had a problem, I'd try to counsel them. But nobody took me seriously because they weren't paying for it. I thought, wow, if I got my license, if I did my internship and residency, I still wouldn't know anything, but people would think I know something. So they'd pay me to talk to me, and then we could have a place to live, and we could get groceries, and and so forth. So I did my residency, but now I'm back where I started because I haven't charged anyone for therapy for 25 years, and I treat everybody for free. And that way I can give a money back guarantee. But I just love treating people, because when people recover, it boosts my spirit also. And now we have mind-blowing techniques that are so far beyond what I was taught when I was a young man, a psychiatric resident. That's my history.
Yeah, thank you. That was brilliant. And of course, you're talking about TEAM-CBT there when you're talking about
exactly. Yeah. Mm-hmm. Yeah. It's kind of like CBT on steroids. It's had several modifications to greatly magnify its power and effectiveness, and to dramatically speed up the time required to recover.
Brilliant. We're going to talk about some of that today. So if you're okay to share, I know that anxiety has affected you in the past, and what was your experience of kind of recovering from disordered anxiety? And in particular, did you use ERP exposure as part of that recovery?
Oh, yeah. When I wrote my book, I used many techniques with patients. And I always say that exposure is not a treatment for OCD or any form of anxiety. It's just one tool and a toolbox. It has many other tools, but it has to be a part of the treatment for every anxious patient. And if the patient refuses to use exposure, I will refuse therapy. Simply on the fact I wouldn't know how to cure you without using this tool. Now I've got 30 other tools you're going to love, and they'll help you too. But we've got to include exposure and response prevention. When I wrote my book, When Panic Attacks, I started counting up all the kinds of anxiety that I've had. And by the time I published it, I realized that I've had at least 11 anxiety disorders myself. And then in the 6 months after it was released, I remembered 6 more. That brought the total to 17. And so I think that's why I love treating anxiety, because whatever you've had, I can say, oh, I've had that too. And I know how sucky that is. And I can show you the way out of the woods. And it's going to be such a joy for you and such a joy for me to help you get over your OCD or your panic attacks or your public speaking anxiety or your shyness or your chronic worrying or whatever it is. I had a blood phobia. That was one of my many things. That's one of the reasons I dropped out of medical school twice. I mean, medicine was just not my thing at all. I had no aptitude for it. But when I finally did my internship, I went to the county hospital, And I told the director, I've got to start my internship here in a month. And I was a terrible medical student. I cut most of my classes. Okay. Could I just work here in the emergency room for free and see if I can learn some medicine? He says, sure, we'll put you on 7 days a week, 12 hours on and 12 hours off. You can sleep here too if you want in the emergency room at the residence quarters, and we'll make a doctor out of you. And the first day I was there, I heard the sirens coming. And I said, oh no, because this was a major trauma hospital. And I said, oh no, I hope it isn't something bloody, because I had this intense fear of blood that I'd had since I was a kid. And all of a sudden, the police were running and the paramedics pushing this gurney at full speed down the hall to the major trauma room. And when they pushed past, I saw this body covered with blood. And I said, oh no, this is not for me. And all the doctors and nurses rushed in, and one of the nurses grabbed me and said, come, you've got to help us. And I said, well, what's up? And she said, well, this man is a bomber, and he was going to bomb City Hall here in Oakland. And his bomb blew up in the basement when he was working on it, but he's still alive, and we're going to try to save his life. And you've got to help me. And she pulled me over I had to look into the room where he was. And there were about 8 or 10 doctors and nurses. They were sticking needles in his veins and putting in fluids with blood pressure cuffs to try to keep him alive, not to go into shock. And I said, well, this isn't exactly my cup of tea. What did you want me to do? And she handed me a toothbrush. And she said, you get busy with this. I said, a toothbrush? What, does he have bad breath or something like that? The guy's on the verge of death. What am I going to do with a toothbrush? And she says, no, stupid. And then she pulled me up right next to his body, which was freaking me out. And she says, look at his bloody tissue all over there. You see those black dots? That's gunpowder. And someone is going to have to scrub it out of his flesh, or he'll die of poisoning. And that's your job. And I couldn't say, well, tomorrow will be a better day. I had to confront my fear. And I started, and this was, I don't think we were using gloves in those days. And I had to put my hands in this bloody tissue, and he was in a coma, fortunately, so he couldn't feel it, but get all this gunpowder out of his wounds. And for 20 minutes, my anxiety, I was freaked. I was 100%. But I had no escape. I couldn't, tell them, I'll do this some other time. And then after 20 minutes, I had the thought, my gosh, this is just a Humboldt County hospital, and these people have incredible skill. They're going to save his life. I can't believe it, how they're just like ants working together beautifully. And I'm actually a little tiny part of that team. And within the next month, I'm going to become a real doctor. And I'd never considered it. I never wanted to be a doctor. And it hit me like lightning, and my anxiety went from 100 to 0. And that was exposure. And that was one of the greatest months of my life. I just loved working with trauma, with complex things, with bloody things, and helping people that way. And if I hadn't been totally committed already to a psychiatric residency, I think I would have been a trauma surgeon or an emergency room doctor or something like that. But that's just an example of exposure. But notice the motivational dimension is important also, because I had a fear of blood from the time I was a child, but I had no motivation to get cured. I just wanted to avoid it. And that's what most anxious people do, what most OCD patients do. But here, I wanted to become a psychiatrist. I wanted to change the direction of my career and my life. And so I was willing to go into that and confront my fear. So that was a simple example of OCD, not of OCD, but of exposure, which is critical for all forms of anxiety, including OCD.
Yeah, no, fascinating story. And I actually have a question later on about motivation,
Sure.
because especially with exposure, like it can be hard to get motivated sometimes. And as you say
Sure.
there, you had a real reason to be motivated.
Yeah.
I guess on that, actually, let's just continue on it because I'm blabbering
Sure.
about it. Yeah, so
Babbling
motivation
is fun.
So I know TEAM-CBT motivation is a big part of that, right?
Mm-hmm.
So is there anything, very general question, that you just want to say on motivation? I guess specifically around ERP, on helping people
Well,
get
sure. A big part of TEAM-CBT, it's testing, empathy, assessment of resistance, and motivation. That's the TEAM. So A is the assessment of resistance and bringing resistance to conscious awareness and then melting it away with a variety of techniques. And there's two kinds of resistance. For any target, whether the target is depression, anxiety, marital conflict, addiction to alcohol or whatever, and one is called outcome resistance, and that's where the patient doesn't actually want a good outcome or is ambivalent about a good outcome. So maybe the person with OCD doesn't really necessarily want to be cured of the OCD. And then the other is process, or the person with depression has mixed feelings about letting go of the self-critical thoughts that trigger the depression. And so you have to be able to deal with outcome resistance. And then process resistance is the patient might very well want to get better, but does not want to engage in the process of the treatment. And so the process resistance for anxiety is exposure. That's the one thing that every anxious patient will not want to do, that they must do if they want to be cured. And when I work with anxious patients or depressed patients, I'm not trying to make people feel a bit better. I'm trying to make the symptoms go away 100%, so the patient can go into a state of joy. And in the case of anxiety, even come to love the things that you were once afraid of, like my fear of blood and the fear of having to be a doctor. So those are the two forms of resistance, and the way we deal with them. For example, in one of my Feeling Good podcasts, I had a woman on who had asked me if I could treat her OCD. She'd had the very severe kind that Howard Hughes had, where she was washing herself constantly for fear of germs and dirt. And she had that problem for over 20 years and spent, hours a day and taking the shower. And when she would come to Stanford, to our psychiatry building, she would have to have cloths to open the doors. She didn't want to touch the doors. Door handles were especially terrifying to her because so many people touched them when coming into the building, and that type of thing. And so, initially, and I treated her live in front of my Tuesday training group at Stanford. And, first you measure the symptoms. That's the T equals testing. And she was, of course, 100% anxious and pretty despondent and depressed and ashamed as well, and with some feelings of hopelessness. And then I empathized for maybe 20 minutes, 25 minutes, just to let her talk and not try to help her, just to be with her, to let the feelings come out. And then we did the assessment of resistance. And the first thing was to ask her, what would be your goal? Suppose a miracle happens tonight. I can't promise a miracle, but if one could happen, what would that miracle be? And she said, well, if I could be cured, by the end of the evening, that would be a dream come true. And I said, so if we had a magic button here and you press it, you'll be instantly cured with no exposure, no effort, no nothing. Would you press it? And like almost every patient, she said, oh, I'd press it in a heartbeat. And then I started to do something paradoxical with outcome resistance, because I wanted her to see that part of her really didn't want to be cured. So I said, before we press that magic button, and there is no magic button, but I do have some pretty magical techniques, and it's possible, even likely, that you will be cured before the end of the evening. But before I would agree to use those techniques, you'll have to convince me that you really want this. And let's list all the good reasons not to be cured. Let's list the benefits of the OCD and what it shows about you that's positive and awesome. Everyone calls this a disease. Let's look at the other side of the coin. What's really beautiful about it? What are some benefits? And she says, well, for one thing, it shows that I want to keep myself healthy. And I said, well, that's a beautiful thing. Put that number one on the list of positives. And then she said, and I also want to keep myself healthy for my daughter and my husband. And I said, well, put that down. It shows your love for your family. And then we went on and on and on. What did this show about her and her core values as a human being that was positive and awesome? And then we came up with a list of 12 or 15 really great reasons not to change. And then I gave up my role as the therapist, and I became her. I became her subconscious resistance. And I said, well, given all of those beautiful, valid, overwhelming positives, it isn't at all clear to me why we should try to make this go away. Can you convince me of that? Do you see? And that's the mistake that most doctors make. They try to convince the patient, and that has an almost 100% failure rate. And I don't at all. I sit with open hands, and I say there's plenty of good reasons not to get rid of your depression, not to get rid of your shame, not to get rid of your anxiety, not to get rid of your OCD. And those reasons are tied into what's most beautiful about you as a human being. So before we take that step, let's see if that's what you really want to do. Well, of course, when you do that, it heightens the patient's determination. She starts saying, oh, I'll do anything. I really want to change. This is the most important thing in the world to me. And so then you go into what's called process resistance. And I said, okay, then let's see if you can afford the price of change. Because here's what I'd ask of you tonight. Now, I've got all kinds of cool techniques that are not going to frighten or upset you. But there's one thing that's going to freak you out. And I don't mean 100% anxiety. I mean 200% anxiety. Because if you want to be cured tonight, we're going to have to go right now with these 30 students who are watching us, and we're going to walk right out of here, and we're going to walk right into the women's restroom. And you and I are going to put our hands inside the toilets and touch everything in there. And she freaked out. She said, oh, no, I couldn't do that. I said, no problem. Then we don't need to treat you tonight. Thank you. It's been great knowing you, and, have a good life. I'm disappointed because I was really looking forward to curing you. And she says, no, I'll do it. And so we got up and we traipsed into the women's bathroom. And first we put our hands on the top of the toilet seat, where people sit. And she made me do it first because she was scared. So I did it, and then rubbed my face like this. And then she decided to do it. And not only did she do it, then she pulled the toilet seat up and started touching the inside of the toilet, which was awesome. I said, how anxious are you? She says, 200%. And I says, great. Now I want you to keep it as high as possible for as long as possible. So let's just go out now and start touching all the door handles between here and the front door to the building. And she said, oh, do I have to do that? I said, that's mandatory. And so I started touching them, and then she started touching them. And we eventually worked our way out to the front of the behavioral sciences building, the outpatient psychiatry building at Stanford. And there was this gross garbage can there. And it was empty, but it had like a 1/4 inch of slime or a couple of millimeters of slime all on the inside of it. and all over the inner walls. And so I said, okay, now I want you to put your hands in here and rub your hands in all this slime. And she says, oh, I'll vomit if I do. I said, all the better. Just get your hands in there and vomit all over everything. And she said, oh, I can't do that. You do it first. So I said, sure. So I put my hands in there, and then they were all black with this goo, and I put it all over my face like this. And I said, now you go for it. So she put her hands in there. She didn't vomit. And then the students all started cheering. And one of my students had his video camera there, his cell phone that had a camera, and he started filming it. And then she took her hands out like she was triumphant. It was like an incredible thing. And then we traipsed back to the seminar room and sat down, and she started crying. And I said, how do you feel right now? And she says, my anxiety is zero. I'm cured. I can't believe what just happened. And it was so moving. And I got chills just thinking about it. And she's been great. That was 2-3 years ago. And she's been on a high ever since. And she touches the floor and all kinds of things. I've had her come actually to a live workshop I did in Atlanta, Georgia, and she came and stood up in front of the audience and rubbed the floor and rubbed her face and stuff like that. But that's exposure and response prevention, and that's just or exposure, I would say, and preventing the response, which is avoidance. And it's one important part, but not the whole picture in the treatment of OCD or any form of anxiety. There's other really amazing tools as well.
Yeah, absolutely. I'm going to ask you about one of those tools in a minute. But yeah, I guess for my listeners, because they're well versed in ERP, because a lot of the episodes I do have been on that, and a lot of them are doing it in therapy. That was a really good story, anecdote. And that was obviously flooding, and it happened very quickly.
Yeah.
But I guess for my listeners, do you also do it graded for those that can't do what that lady did?
You can do it graded or flooding. I somewhat prefer flooding. That was my experience in the emergency room at Highland Hospital in Oakland, because you kind of get over it really fast. And that's worked for me in a number of capacities. But gradual exposure can also be very effective. And whatever you and your therapist or whoever's coaching you, whatever you're most comfortable with will work very effectively.
Okay, cool. Thank you.
I might say one thing that I want to clarify here. Most people, when they hear this story, are very cheered by it. But after I posted that podcast, and I get thousands of emails from people, and usually they're so warm and enthusiastic, but I got a couple kind of hate mails. Like one fellow just wrote in "F you," and another one was just outraged because I think these were people who had suffered and struggled unsuccessfully with OCD or depression, and so it might sometimes sound like I'm trying to trivialize someone's suffering or say, "Oh gosh, you can get cured." Really, that woman was cured in that 3 minutes in front of the hospital. That really happened, and it was just one session, and just a small portion of that session when the cure actually happened. But I don't intend to trivialize anything, because depression and anxiety are some of the worst forms of human suffering, maybe the worst. And of course, I've experienced that myself, that intense fear, the intense panic. I've had fear of heights, all kinds of intense fears. I've had public speaking anxiety. My first talk was at Oxford University, my first talk of my academic career. And I had the fantasy that it would be a nightmare. And I couldn't sleep the night before. It was at this very prestigious conference, and I fantasized that I was attacking the work of someone from the National Institute of Mental Health. And I heard he was a bully, and he liked to belittle people in conferences. And I had the fantasy he would sit in the front row and start screaming at me after my talk. And that's actually what happened. It was the most humiliating experience of my life. And I gave the worst talk. I just read and mumbled my talk. I was so scared. And so I know what anxiety is like and what the consequences can be like. And but it just, I love treating anxiety because in most cases you can deal with it very effectively, but it requires trust as well with your therapist, and it requires melting away that resistance. And if you just throw these techniques at patients without developing that trust, the empathy, without knowing how to melt away the resistance, then they'll kind of fight you, and the therapy can go on for months or years without meaningful progress.
Yeah, well, thank you for clarifying that. And on this podcast, I try and get many different perspectives because I want the listener to make up their own minds. And if they disagree with something, they disagree with it. But for someone, it's going to resonate, and that's what's important.
Yeah, exactly.
So your hidden emotion model, that's what I want to talk about next, because that's really what brought you to my attention several years ago. I think someone shared it with me, and then I listened to one of your podcast episodes on it and found it fascinating. Oh, yeah. So I guess two-part question is, what is the hidden emotion model? And also if you could share any sort of case examples of it.
Sure, I can do that. I'm happy to. It's a kind of high-speed, simplistic form of psychoanalysis. Because it's based on a Freudian concept. Most Freudian stuff I don't go for. But this is one thing that really panned out. And it's the idea that the vast majority of patients who struggle with all forms of anxiety, with any form of anxiety, are exceptionally nice people. Yeah. And the niceness is one of the important causes of the anxiety. And what that means is that some of us, like I was a minister's son, and I don't know if upbringing has to do with it or if it's a genetic thing in the brain, but we were all supposed to be nice to everybody. And if you have that mindset, if you get a forbidden kind of feeling, like you're angry with somebody or you're in conflict about something, you sweep it under the rug and try to push it out of conscious awareness. And then it comes back in disguised form as anxiety. And the anxiety is generally the subconscious mind, or whatever you want to call it, the part of our mind that we can't quite tap into, expressing itself when you're unwilling to do it with your mouth. And when I started treating depression, I got tremendous results. When I then tried to apply cognitive therapy to anxiety disorders, I got excellent but not tremendous results, because some people would get stuck. And I didn't know why. And it wasn't happening with my depressed patients in quite the same way. And then it dawned on me that the anxious patients often had something that was eating away at them that they hadn't told me. They hadn't even admitted it to themselves. And it's generally something you're unhappy with in your current life. It's not some traumatic memory from the past. It's never that. But it's a traumatic, it's buried in the present is where it's buried. And the first time I discovered this, it wasn't OCD, but it was a very anxious woman who was having panic attacks at work. And every time her boss walked past her desk, she would have this uncontrollable urge to vomit on him. And she'd have to go and lie down in the ladies' room and then eventually go home because she was sick. And I tried all of my cognitive stuff, and I couldn't get her over this. But she was very motivated and very pleasant. And 6, 7, 8 sessions in, she was still having panic attacks, still going home from work. And then it kind of came out because of her. She was the one who taught me. She wasn't trying to teach me, but she kind of revealed to me that she had always been the good daughter growing up. And she had a sister who was the bad daughter. And she said she always had to get straight A's and be the class president and work as a waitress during the summer to earn money for college. And her sister, who was the bad daughter, got to do all the fun stuff. And she said, but actually, that was just one of your cognitive distortions in our family, like all or nothing thinking, because I'm not all good, and my sister isn't all bad. In fact, she was a wonderful human being. She did great in school, and she's a mother, and she's got a great job. And I'm not always as nice as what people think. And I said, well, what do you mean? And she said, well, tell you the truth, I love my boss, and he's been so kind to me, but I'm selling soda pop. And this isn't what I want to do with my life. And I said, well, what did you want to do with your life? She said, I always dreamed that I would design women's sportswear. I'm a great artist. I've been drawing clothing since I was 5 years old. And now I'm finally out of college, and I'm a soda pop salesperson. And I make good money. I'm treated right, but this isn't what I want in my life. And that was the hidden emotion finally came out. And you see, she thought she wasn't allowed to want what she wanted. She had to do what other people wanted her to do. And I said, well, for homework, talk it over with your husband, talk it over with your dad, talk it over with your boss, and tell them how you feel. And she came back the next week and said, this is my last session. I'm cured. My panic attacks disappeared. I said, what happened? And she said, well, my dad, my husband said, well, go for it. Do what you want to do. And I told my boss that I was so admiring of him and so grateful, but I always wanted to pursue a career, if I can, designing women's clothing. So I'm going to give you notice, but I won't leave until you've got the person you want to take my position, and I'll help train that person. And that was it. I never heard from her again. And except 6 months later, she sent me a note thanking me, saying she was still on a high, no panic attacks. But she said she just took 3 months off to relax in the backyard and, get her bathing suit, get a suntan, and do the things she could never do, and because they didn't have any money when she was growing up. And then she said she got a job as an apprentice to a woman who manufactured women's sportswear and designing clothing. And she said she just couldn't be happier. And I thought, well, that's a fluke. But then I began to see it with all of my anxious patients, and including and especially OCD patients. And it gave me another powerful tool to bring about rapid recovery for many people. Let me see if I can think of an OCD example. Probably one you heard on the podcast.
The HIV one.
That one. That's a great one.
Yeah,
sure.
Share that, yeah.
Oh, yeah, sure. Yeah. This was somebody referred to me who had had years of treatment for OCD. He was a medical student and a brilliant one. And he kept thinking that he had HIV. And so he'd go to the emergency room and persuade them to give him a blood test. It's always normal. He was engaged. He and his fiance were faithful to each other. And there was no reason for him to think that he could get HIV, but he'd think, well, maybe I took blood from a patient with HIV, AIDS in the hospital, and then punctured myself with the needle and forgot. And how can I know for sure? And then he'd start checking his body and reading up on HIV and AIDS. And he was probably knew more about it than almost anyone in the world. And then he'd eventually go get a blood test. And I hit him with everything I could. His previous doctors had failed completely. I was failing completely until he called me on a Saturday morning with an emergency. And I said, what's up? And he said, well, my fiance just left for her high school reunion in New England. This was Philadelphia, where I was at the time. And I have my finals coming up. So I stayed home to study all weekend. But 15 minutes after she left, I started to think I was dying of AIDS. And I have the compulsion to go get another blood test. What should I do, doctor? And at that moment, I finally understood what was going on. And I said, here's what I want you to do. Come Monday, I've got an emergency session. I can see at 7:30, real early Monday, and bring your fiance with you. I think I know what's happening. And it just dawned on me, he must have some feeling there that he was afraid to express. And I asked him about it on Monday, and he said, well, I was feeling kind of lonely when she left. Do you think maybe he was feeling angry and maybe she was going to have an affair with somebody? It was nothing like that. But he said, I felt lonely. And I said, well, why didn't you tell your fiance? And he said, well, I thought that was not a manly thing to do. And that's, you see, OCD speaking, I'm not allowed to have the feelings that I have. And I said, and he said, I'm afraid she'll judge me. She'll think I'm a wimp. And I said, check it out. Let's do an experiment. Tell her how you were feeling. And he told her, and she started crying and hugged him. She said, I love you so much. I feel so much closer to you when you tell me how you feel inside. And he could not believe it. And the next session, it was his last. He said, I'm cured. My OCD is gone. And I said, well, the great news is you're now cured permanently and irreversibly of OCD. And the even better news, it'll come back over and over again for the rest of your life. And he says, well, why is that the even better news? Because I said, you'll probably never figure it out in real time. You'll get better at recognizing your feelings, but you'll still sweep them under the rug. But now you'll know that's your body telling you that you're upset about something. So whenever you get the OCD symptoms, you think you're dying of AIDS, it'll always be the same thing. Just check your appointment book, figure out who you're upset with or what you're upset about, do something about it, and then your symptoms will disappear again. And he said, thanks. And I never heard from him again for 30 years. And then he called me not long ago and said, do you remember me? I said, do I remember you? It seems like about a week or 2 weeks since we last talked. I can remember every conversation we had. How are you doing? He says, oh, I'm doing great. And I'll disguise the details a little bit, but he says, I'm the chairman of the cardiology department at Harvard Medical School. I said, congratulations. I'm not surprised, but that is really awesome. But what are you calling about? He said, well, I'm doing research on anxiety and the heart. And I'm wondering if I could use your anxiety scale. I said, go ahead. God bless you. Absolutely, you can. And good luck with that. And I said, but what happened to your OCD? He said, it was exactly as you said. 99.9% of the time, I have no OCD. But maybe once a year, twice a year, I'll start to think I better get a test for HIV. And then I know I must be upset about something. So I look through my appointment book and then I figure it out. And then I talk to the person I'm upset with and it disappears. So yeah, that's a perfect example of it. And again, this is only one tool in a toolbox with many other tools, but this is just a fantastic one. And a lot of the people who are treating OCD or any form of anxiety or depression, they want one thing to do with their patients, one simple thing to learn. And I've developed over 100 tools for treating depression and anxiety, and they're all of value for different people because you never know what technique is going to work for what patient. But this is a huge one, and it's beautiful because it shows you, takes the mystery out of anxiety. Freud said anxiety is the mysterious emotion. It comes from out of the blue. It strikes like lightning without rhyme or reason. And nothing could be further from the truth. Anxiety never comes from out of the blue. It never strikes like lightning without rhyme or reason. It comes out of a human context. And it makes recovery a lot cooler thing because you're not recovering from an illness, but you're discovering that there's more than you thought to being human. and that we have a lot of kinds of emotions, not just always the so-called proper variety. Sometimes we want things we think we're not supposed to want, or sometimes we get angry and we think we're not supposed to get angry. And once you shed those notions and realize that it's okay to have feelings and to share them with people, that's more than just recovering from OCD or panic attacks. It's adding a richness to your life. And now I share a lot of things when I'm teaching and talk about my own vulnerabilities and times that I have felt upset or anxious or depressed or down, and what things have helped me. And I talk about mistakes that I've made with patients and mistakes in my life. And I've found that my students appreciate me more, not less, when I'm more open.
Yeah. I agree with that. I had this conversation yesterday with someone pretty much about that. We kind of got on about politicians, and if they just admitted when they did something wrong and apologize, we'd respect them more. Not
exactly. Yeah, exactly. Yeah, Biden made that mistake, and I don't blame the guy, because he's so much better than what came before. But he got all defensive about the exodus from Afghanistan. And I wish he'd said, gosh, I kind of screwed up on that. And I wish we'd planned it much earlier and done it much earlier. And I will make mistakes, but when I do, I'll always own up to them. And you can trust me on that.
Yeah.
But
wouldn't that be refreshing?
Yeah.
In the UK too. Okay, so I'm realized run out of time. So in the last 5 minutes, random questions now. So if you could pick up the phone and call the 20-year-old David, what would you tell him?
The 20-year-old David was the one who was still in college, I guess, right? I'd say just go for it. Do what you're doing. You've got a great life ahead of you, and follow your dream. It's okay to do that.
Yeah.
I'm so glad I left academics. And I've published so much research. And now with the app I'm developing, I'm going to have data coming out my ears. And I get to do mathematical modeling all the time now. And we make discoveries almost on a weekly basis with the data we're getting from the new app. And but I would also say, David, you made a good move to do the formal thing, to get your residency training, because that gave you some credibility. And you're going to discover that you love medicine after all, and you became a darn good doctor on the way to becoming a psychiatrist. So go for it. But yeah, I'm just so grateful for the life that I've had. And this has been, I'm just turned 79. This has been the most productive and creative phase of my life.
Really good to hear. Yeah. And then you've got a billboard where you live. What do you want written on that billboard?
An arrow pointing across the street with a little sign that says, David lives over there. So that they don't come and plague me, I guess. For patients, I one thing I've learned is never give up hope, no matter how severe a patient is. I've never given up hope, and that's always paid off. But patients can be very good at persuading themselves and others. I'm the depressed patient who can never recover. I'm the anxious patient who can never recover. And I just never, ever buy into that. I try to empathize and provide support, but the hopelessness is just based on distorted thinking. It's never valid. And if you hang in there, improvement will occur. And once some improvement occurs, you can get more improvement to occur.
Yeah, good point. So lastly, is there anything else you wish you could have shared today about your life, TEAM-CBT or OCD more generally?
No, it's just been a real honor to meet you and to share some ideas with your listeners. And, if they like it and you want to do some more sometime, I eat this stuff up. I just totally love sharing these ideas. It's an honor for me to be on your show and to have a chance to connect with your audience.
Thank you. Yeah, it's been an honor to have you on and hear all your methods and approaches.
Thank you for listening to this week's podcast. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/theOCD stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.